Going. Can you guys see my slides?
Yep, looks good.
All right. So today we're going to talk about risk reduction and community overdose prevention. So risk reduction is now the safe word for harm reduction, overdose prevention. They're all interchangeable. They all mean the same thing. We're going to define what risk is and explain the role in community overdose prevention as a part of the continuum of care, identify key strategies that reduce overdose risk, including test strips, naloxone education, and community-based programming, and then identify ways that maybe your agency can include some of these practices. So risk reduction. So I think when we talk about overdose prevention or risk reduction, oftentimes people think this is kind of a new concept that came with the opioid epidemic, right? But it's something that we do every day. So if we think about seatbelts in cars, if we think about sunscreen or prescription labeling, these are all just surrounding how do we make risky behavior safer, right? We know that driving a car can be dangerous, but we don't just all drive 100 miles an hour because we have a seatbelt on, right? And so really taking that philosophy of what risk reduction is and understanding it doesn't eliminate risk, right? It just makes things safer. And the hope is preventing death. Um, so some common risk factors for overdose. And we're seeing this a lot lately, right? In the last handful of years, unpredictable supply and potency, mixing substances, reduced tolerance after a period of abstinence. We're going to talk about that more in a minute. Adulterated drug supply. So what we're finding in our community is that there is adulterants in our drug supply, and many of the people who use drugs don't understand what it is or even know to expect it. Um, Using alone, lack of naloxone, and then a combination of different health issues can also increase someone's overdose risk. So there are predictable times when overdose risk is extremely high, and it's especially after a time of abstinence and when tolerance is dropped. And these are really critical intervention opportunities that we can have as providers for people coming in for services, or we can educate about naloxone and connect them to overdose prevention programs and to tools that can save their lives. I feel like I skipped a slide. Just a moment. Okay, maybe not. That was a really quick introduction to risk, what the risks are for overdose. I think if I wanted to expand on that a little bit more, you guys, I would just really talk about, I don't know about your services, but we serve a lot of people who are on probation and parole. And so we get a lot of people coming straight out of incarceration. And, my experience going out to the prison and talking with people who are developing a plan for release is that, I know I've got to do treatment, but I'm really just set this time that I'm not going to go back to use, right? And so I'm going to go do these classes, but I think I'm good. And we really try to have some in-depth conversation about, what was your substance of choice? And if it's opiates, and how long have you been incarcerated? Because the opioid landscape has changed significantly out in our community. Where historically we had heroin mixed with some fentanyl, now we have the absence of heroin in my area in Boise and the overwhelming presence of fentanyl. And it's not in pills and it's mostly powder form. And people coming out of incarceration aren't expecting that. And they don't always understand, like they hear the difference, right? They think they know, but really just having those in-depth conversations with them about what that means for their own personal risk. And that's when connecting them to services like ours or any of the other agencies in the community that provide overdose prevention is super helpful. Um, so the ways that we do this at Trivium is through grant funding. And one of our grants that I really appreciate and enjoy the most is our naloxone distribution boxes and our community overdose prevention. So these are our naloxone distribution boxes. Naloxone is obviously one of the most effective prevention tools that we have. We have several of these boxes throughout the community. We have one in Mountain Home, and partnering with agencies such as BHG, LADA, the Hive. We just got one in the Shredder, which is a music venue in Boise. We just partnered with some vape shops, so we're going to see some boxes being put out into the community and the vape shops, which I'm really excited about. But these boxes are amazing. So they look like the old school newspaper boxes, and people, anybody, can go up and access them. It's anonymous, which is a huge win for overdose prevention, is keeping people's privacy. Um, the only requirement for these is that they have Narcan and CPR masks. But the majority of our host sites also include fentanyl test strips, xylazine test strips, chamber locks for guns, condom kits for safer sex use. For a minute, we had an overwhelmingly large donation of monostat, so we were able to put free monostat out into these boxes, which is really great. Hand warmers, just anything we can think of that the site thinks would be beneficial to the people coming into their agency. This is Vendi. So Vendi is we call her now a public health vending machine. She used to be our harm reduction vending machine. She got a name change. And she is in our office. And this vending machine has everything that you can think of in there for overdose prevention, including wound care kits, hygiene kits. We've got backpacks in there. We've got toothbrushes. And really, our stock in this vending machine just really is based on what donations have we gotten or what funding do we currently have. Test strips are incredibly important, and I don't know if they're distributed enough or talked about enough with our clients or with the people we encounter. Um, they obviously don't tell somebody if their supply is safe, right? It's not going to say there's X amount of fentanyl in there. You know, it's safe to use. It's going to say, yes, there is fentanyl. But going back to what we were talking about with the supply in the valley, everything, we can assume almost everything is fentanyl in our area, right? And so we really encourage people who are using anything other than fentanyl to test for fentanyl. And that includes pills that they've purchased. It includes Xanax and Adderall, MDMA, ecstasy, methamphetamine. I don't know if you guys have had the conversation about cocaine making a resurgence in our valley, but it is. They're finding that it's can be cross-contaminated with fentanyl. Um, and anyone who's using fentanyl, the conversation then for us transitions to xylazine. Um, when we first started testing for xylazine at our agency, it's because we were having so many fentanyl analogs test positive in our urine drug screens. And our lab suggested we start testing for xylazine. And it wasn't very long at all before we had this wave of positives. We don't see it consistently. We see it as the drug supply into the state changes. It can ebb and flow. But when we talk to clients about what xylazine is and that they tested positive for it, many of them didn't even know what it was, and they didn't anticipate it being in their supply, but they said, you know what, that makes a whole lot of sense because I used the exact same amount and I got it from the same person, right, that I always use. But I had this significantly different response to the substance. Um, and so we talked then about you can approach and be like, maybe now's a great time to stop using fentanyl, right? But really the more realistic conversation and probably the better heard conversation is about safety and about what options do you have? Is there a different supplier? Is there, do you know where to get test strips? If you test positive, if your substance tests positive for xylazine, what's your next step? Do you know that it's not incredibly responsive to Narcan, right? Do you know there's increased risk? Um, and that's one thing I really appreciate about overdose prevention is that we're not condoning substance use, right? We don't shy away from the risks that are involved with substance use, but we don't stop there, right? We don't just warn of risk. We then help create safety plans, right? And give options for how can you make this experience the safest it can be based on what you're using. Uh, Outreach is my favorite thing that we do here at Trivium that I'm involved in. So we've been going down to Cooper Court, which, if you're familiar with Boise, it's right down by Corpus Christi, the little road that led back to the old Interfaith Sanctuary. And we've been going there since October of 2023. And we go at least every other week. and we work out of the back of my truck. And we take all of the supplies we have available in our vending machine and our Narcan boxes down to the community. Um, this is a big step forward in reducing barriers because we're not waiting for clients or community members to enter into our agency to access our supplies. We're taking them to the community. Um, Education is a huge part of what we do down there. With xylazine, there's an increased chance of wounds that we haven't really seen a whole lot here in the valley, luckily, right? But as we start to see xylazine show up more, that risk increases. Um, we don't just get to distribute supplies, we're there to offer connections to the uh, recovery community if they want that. And oftentimes that means referring back to our own agency, but understanding that there's a different hat, lid for every pot that, sometimes we refer out. If they want methadone, then we're referring to Raise the Bottom or to a behavioral health group, or one of the other providers in the valley. If they need linkage to housing, then we've got Catch right there. Um, Really, it's about going down there and building rapport and trust. And I can tell you when we first started going down there, I think Sarah's on the call. She was with me the first time we went down there. And I just thought this was going to be the greatest thing ever, right? We got all these supplies. We want to do good. We're going to go down and it's just going to be great. And people were leery of us, right? And I can look back now and be like, oh man, that makes a lot of sense. Um, it took a lot of time to build that trust with the community out there. And we're not just inviting them to come get what they need supply wise, we're inviting them to come have some conversations about something that has so much stigma attached to it. And there's so much fear attached to being caught with, you know, a controlled substance on you that, of course, that rapport has to happen first. Um, we've got people down there that we get to serve that have been there the entire time we've been going down there, and we've built some really good relationships with them. And we've seen a lot of change for themselves, right? They maybe they get housing and then they end up back down there. Um, Maybe they go to treatment and they end up back down there. And we're always just going into it with a how can we be of service attitude. I was talking last night with some NNU students, and it was really an approach of humility um, and asking questions like what would be best to serve this population, and not always assuming that we know what is needed. Recovery coaches, I saw that we had some peers on here. One of my favorite aspects of treatment and also overdose prevention, because I really believe that recovery coaches are often the bridge between an overdose event and the potential for recovery. So we have a grant here, which we call WOG. It stands for the Warm Handoff Grant or Program, where we get to go out into the hospitals and meet with individuals who present either at the ED or get admitted for something. It doesn't have to be directly substance related, right? So obviously we get people maybe going in for alcohol detox, but oftentimes we're encountering people who have been admitted onto a floor we had one guy that had a gastric bleed, and he got in there and they got admitted, and they discovered he has an alcohol use disorder, and that's contributing to that. Um, and so myself or my recovery coach Andrew get to go out and meet with people bedside and just come in with a curious attitude, right? Like, what brought you here? What do you want to do? Do you want to engage in treatment? Do you want to try some 12-step programs? Do you just want somebody that's going to call and connect with you? Um, Oftentimes, what we find is when people are like, "No, I'm not ready for treatment yet. I don't think that's what I need." As we call and we make those connections and we engage people and build that rapport, oftentimes those no's turn to yeses, and then we're able to make a referral out for treatment. Um, and again, we operate this grant, but we don't refer just to us. In fact, we rarely refer to us because oftentimes we're looking for residential treatment care or a methadone clinic. Um, but we get to stay connected with them throughout their journey. So bringing overdose prevention into practice at agency levels. I get asked this a lot at our community provider meetings. They come in and they see our vending machine, they see our Barney box, the naloxone distribution box up front, and they want to know how that they can do something in their own agency. And my suggestion is always to start small, right? If you have naloxone in your office, make it visible so the clients can see it, right? We want to normalize this conversation between our people that we're serving, that we're our clientele, and our staff. Um, if we can normalize that conversation in the times when things are okay, when they start to struggle, it makes that conversation a little bit easier to have. Um, Providing staff with naloxone training. This is huge. We do training, so if you guys are interested in having your staff trained and you're local, I'm happy to come out and do that. If not, I can connect you to somebody. Um, Oftentimes, we're asking staff to have a conversation about something that maybe they don't truly understand. And so their confidence isn't there, their understanding isn't there. And so the conversations don't have the depth that we need them to have if we're trying to arm our clients or the people in our community with the education that could save their life. Um, and including overdose prevention information at discharge. Oftentimes clients don't want to hear about, the risks that could happen if they go back to use when they're graduating because they've come so far and that seems like something that they're not going to go back to. Um, but we're remiss if we're not having that conversation. We know that it often takes more than one, often several attempts at treatment before it sticks for individuals. And so we want to make sure that they have the information and the resources that they need, because going back to overdose prevention is really about keeping somebody alive, healthy, and able to return back to services if they need them. Um, and as we have these conversations with our staff, it reduces stigma. So we're talking with those NNU students last night. Um, we all have bias, right? And some of it we know about and some of it we don't. And as we have further discussion, we start to uncover some more of those biases. There was somebody in there last night talking about syringe exchange is where I draw the line. I can't ever talk about, safer smoking practices because crack pipes just seem too far. And and that's an opportunity to have conversation, all right? Because we know that smoking a substance is far safer than injecting a substance. And also there's an opportunity for transmission of disease through smoking and sharing pipes. And so there's an opportunity just to grow people's understanding and to plant some seeds that may start to reduce some of that stigma that our people face. Some more in-depth strategies. Would be if you want to distribute naloxone to your clients. So the state of Idaho will provide free naloxone for us to hand out to our people. Installing a naloxone distribution box for community access. So we've got the box here in our vending machine. That's open for anybody in the community. Definitely don't have to be a client just to access those things. Um, We've got one box set up over at Icarus, their PHP program by the Department of Health and Welfare. And we're starting to see a trickle in of people from the community that have accessed their location from the map at the Central District Health website. And I think that's just really exciting, right? So people can go in and just grab what they need and not feel the pressure of having to have that conversation about things that maybe they're not ready to talk about. Oftentimes, we can hand out Narcan to parents who don't want to have the conversation about their kid using substances. They're just not there yet, but they want to keep their kiddos safe, and these boxes provide the perfect opportunity for that. Develop post-overdose follow-up protocols for clients. So if you have a client that reports an overdose, like what is your next step? Do we just increase their level of care and call it good? Or do we really do some in-depth planning for what does overdose prevention look like? And how can we inform not only yourself, but maybe the people around you, your family, about naloxone and how to administer it? Um, and it can be implemented in any setting. And that's just something that I don't think everyone understands. Taking naloxone in my purse when we're at a concert and some gal passes out from us she was having a hard time with, I think it was the temperature and she was intoxicated. Um, but we had Narcan on us just in case, right? And that's overdose prevention in any setting. That went really, really quick. All right. So key points that overdose is preventable and the key factors that play into an overdose, it's not always just using the substance, right? It's the substance and also what is in the substance and also What's your tolerance look like right now? Do you have any health problems going on? Are you recovering from the flu and your body's kind of broken down and working overtime to get well? And so if we're using substances on top of that, that can be an opportunity for an overdose. Just things that we don't normally think about. Um, Risk reduction is part of the continuum of care, right? So it doesn't replace treatment by any means. But as we see our clients vacillating on that readiness of change, um, it has a place. Um, it's kind of two steps forward, one step back for the people we serve. And we just really want to make sure that they're prepared for wherever they're at on their journey. Recovery coaches play a huge role. If you guys don't have recovery coaches or peer supports in your office, I'd suggest getting connected to your local recovery centers, and making them a part of maybe treatment planning or just, or your referrals for current clients or clients that graduate or are being discharged. Oftentimes those services are free through the recovery centers, and they can really just support the client in a way that clinically, you guys and myself, we don't. Um, Coming in with that lived experience. Normalizing the overdose prevention conversations is huge. Um, I don't know that we're going to have meaningful conversations if we don't understand what it is we're facing and how we can be a part in the solution towards that. And then just taking small steps in your agency can have a huge impact, on the people you serve and their families. That is it.
Amber, thank you so much. That was a great presentation and lots of really awesome points that you made. Would love to open it up. We've got time for Q&A. We love this. I feel like so often people are like, there's not enough time for Q&A. So we got time. What questions, comments, thoughts do people have? You can put them into the chat or use the raise hand feature or just come off of mute.
Did excuse me. Okay, hold on. Let me learn how to speak again. I thought that was really good, and I feel like Trivian has helped me a lot. I have a few different jobs in the community, and one of the things that you guys have been very helpful in is providing Narcan to it. One of my other places of employment is ironically like a distillery and a bar. And so we have like a high need for that. And my only other question is, I know you guys do a lot of harm reduction or risk reduction when it comes to Narcan and stuff like that. Do you know of any places or resources that do any type of like CPR or like um what's the other word I'm looking for? But are like Heimlich trainings or like if people wanted to get Narcan but they weren't like licensed or clinical staff, is there a training that you do for that as well?
For Narcan or for CPR?
For both. I just kind of
For both.
combine them into one.
We will train anybody and everybody on Narcan administration and how to identify an overdose and what to do. CPR, I would say, maybe the health department would be a good resource for that. Um, I guess I've been kind of lucky in our agency has always brought in a CPR trainer, so I've never had to go search one out myself. Um, but we definitely do Narcan training for anybody. You don't have to be clinical, um, to receive that for free.
I have a question. Could you talked a little bit about having conversations with clients when they don't know what's in their drug supply? What might a conversation look like if somebody found out that there was xylazine in their fentanyl or that there was fentanyl in their meth? Like, how would you have that conversation?
We talk about testing, right? So we want to continue to do that. Um, so when we had the clients testing positive, and it still happens today, testing positive for xylazine, and we talked to them about that. Our hope was they'd find this different supplier, maybe they'd stop, maybe they'd make some change. What we found is like clients were kind of hitting this plateau with their fentanyl use, right? And xylazine's kind of bumped it up a little bit, as it's intended to do. Um, I think it's not a one-time conversation. It's going back and checking in and asking what do they want to do, right? Is this what you want to continue to use? And if yes, then how do we keep you safe? And if no, then what do we do to help you reduce your use? Um, Clients that were using the xylazine, I think were pretty shocked. And then oftentimes there's some denial, right? And so we just motivational interviewing, right? Walking alongside them with those conversations, but really emphasizing risk, but overemphasizing how are we going to help keep you safe? Because we don't want to just drown them out with risk and lose their attention, right? And then have them feel like, this isn't a conversation we can have because you're not hearing, what I'm saying. Is we need to, for me, I need to accept the responses that I get back from clients. I'm going to continue to use. Great. Do you have test strips? Do you know how to accurately use a test strip? Because it's not just you break off a little piece of your pill. You have to go through this whole process. And so really just training people on how to use the tools that are available to them and knowing it's a long haul conversation, I think. I've never once had someone test positive for something they weren't expecting xylazine wise and be like, I'm done. Right. But we've had people who have tested positive for xylazine who have been able to complete treatment because over the course of treatment, they've reduced use and they've found abstinence and they've been successful.
I have a question for you. I'm more in the data collection side of this world.
Mhm.
And so I'm looking at those naloxone boxes that you've got scattered about, and that is so wonderful. But I'm curious if you guys are attempting to track naloxone overdose reversals using
Mhm.
naloxone and how successful you're being and sort of
Yeah.
maybe some of the approach. Yeah, I know. And maybe some of the approaches you're taking.
So, in office, it's really basic. We've got a whiteboard next to our vending machine, right? And every month I change the month on it and it says overdose reversals. And people sometimes will mark if they've used naloxone for an overdose reversal. At outreach is where we get the most, I would say, accurate data. We have people having conversations. We know that there's a lot of overdoses happening in this area down around Cooper Court. We talked to EMS about it. We talked to the participants down at outreach about it, and they report back to us. Well, I was able to use your naloxone or your Narcan, and I gave it to my friend. And so we track data that way. I was just having a conversation with Ken up in Kootenai County about that. Do QR codes work? No. Right? In the midst of an overdose, when someone's busting out the Narcan and they're giving it to somebody, they're not like, save the box. I need to scan the QR code. Because there's adrenaline and people are fearful and they don't think about it afterwards. And so it seems, and I've talked with people in other states about it too, that that is one of the hardest things to gather data on. Although it is one of the most important things when we're looking at grants, right? We need to be able to justify the amount of Narcan that's going out. Um, I do know that there's agencies that have had, so kratom's been a huge topic lately, right? That we could probably spend a whole hour talking about that and more. Where they're talking about they're utilizing Narcan on a kratom overdose. We 7OH probably, right? But and so they're getting data back that way because it's such a hot topic. But I'm sure as soon as the kratom discussion kind of fades away, those reports will too. And so it's difficult. So if anybody out there has a great idea or something that's worked for them for getting Narcan reversal data back, I would love to hear about it. Sounds like Grace would love to hear about it. Ken would definitely love to hear about it. But really, it's just conversations.
Yeah, I actually had spoke to Ken about what you guys are doing, and you guys have the most. I wanted you to talk about it. You guys have the most like personal connection approach, and even though you may not feel very successful, I think you are probably the most successful. So anyway, keep it up.
Thanks.
Great questions, great comments. Any other questions or comments from our panelists or from our audience members? I see that CPR does do most of those first aid trainings, Caitlin. Or sorry, American Red Cross does most of those CPR trainings. And then Joni said that Valor Health and Elmet did one last night. It would be really interesting, seems relevant to combine CPR trainings and naloxone trainings. So yeah. Any other questions or comments today? Stephanie said, is anyone able to speak to Narcan acquisition for larger groups versus individuals using vending machines, Narcan boxes, etc.?
Can you tell me a little bit more, Stephanie?
Yeah, so I used to be familiar with Idaho harm reduction, and I know since they lost funding, I haven't been super sure about who and where to kind of reach out to get Narcan for. Like I work in a community college, I would love to make that more available for my students, things like
Absolutely.
that. So like 30, 50 orders of like 100 boxes. I don't want to deplete your vending machine, your boxes. Just curious of kind of any ideas of where to go for those larger orders like that.
I would be happy to supply you with that. And
Okay.
also, Kootenai County Fire
Okay.
manages Narcan distribution. But we're happy to do that. It's where we get our Narcan from. So Kootenai County Fire does it for free. It's through a grant funding, like Grace was asking for that data. Um, and so you can order it through them. But we're also, if you're in our area, happy to be your point of contact.
Okay. Awesome. Yeah, thanks. And some people think there's some stuff. I'll look into that or reach out to you, but I appreciate it. Thanks for what you're doing.
And it looks like Grace just put in there that IDHW has an naloxone request form. So she just put that link in where you can request that.
Yeah.
Dave, did you have a question?
I just had some information for everyone regarding CPR and Narcan training. American Heart Association has a course called Heart Saver, and that teaches not only BLS CPR, but some other emergent first aid things, and it also teaches about Narcan use. So I'm assuming you could go on the American Heart Association website and ask about local training centers that provide those courses. And it's called a Heart Saver course.
That's great. Thank you so much, Dave. That's great information.
I do
Uh,
have a question as
yeah,
well, if that's okay.
of course.
I've heard people say that, well, if you're providing Narcan and this kind of help for other resources for people, really you're just promoting them continuing on drugs and you're not really being helpful. And which, we know that's not true, but what kind of good responses do you make to counter that sort of information that they think they have?
I can talk from experience with having our vending machine. So we had our vending machine in the before times when syringe exchange was legal, right? And we had syringes in our vending machine with an office of almost 400 clients enrolled in treatment. And what we didn't see was an increase in overdoses. We didn't see an increase in discharges related to return to use. Um, we what we got from that, I think what is incredibly important was that opportunity to be both a treatment provider and a provider that said keeping you safe and well is a priority so you can continue in care, right? And I would just go back to that. When we saw prohibition happen with alcohol, it just went underground and then people were dying at a much larger, faster rate because of there was no regulation. Um, when we provide resources for people to continue to be safer, we don't see people going crazy with an increased substance use. What we see is trust being built, knowing that they have a safe space to come talk to and talk to us or to you guys when things get scary or when they experience an overdose, they know they don't have to like put their head down and shy away from treatment. Um, really, this is all about, you know, seeing people and making them feel valued despite the fact that they're using drugs, right? Treating them like humans, which is crazy. And uh, I don't ever go into a conversation where there's opposition to what I do, thinking I'm going to change the person's mind with that one conversation. But I offer like my experience of having this program in our office and not seeing negative outcomes come from it. Um, and being able to talk more about the incredible amount of positive outcomes we saw and the changes we saw in our relationships, not only with our clients, but with our community. It opened up conversation with probation and parole. Amy and I went to meetings with D4 probation and parole and would just get hammered. Hey, what do you mean you're handing out syringes to our people on probation in your treatment center? That's crazy. Uh-huh. We care enough to try something crazy, right? And here's the data that backs it up. Um, and over time, we'd win some people over, right? Um, but I think it's just it's a long game and it's not a short game. And so using, your other agencies in your area, their experience, if you don't have an experience of it in your own, is helpful. But I can also tell you when they banned syringe exchange, they said this is going to stop people from injecting drugs. We're doing a good thing. There was a standing sharps container down at Cooper Court that was like drilled into the concrete. Anybody could access it in the community. People didn't stop injecting drugs. They took a drill and drilled out the lock to get syringes because that was the level of desperation of our community. And that's not safe, right? Now, not only are we using
Wow.
drugs, now we're sharing used syringes. And so it only made the problem bigger. But we say that in a really, I guess, kind way so as not to attack people that we're talking to about that, right? Like your plan didn't work. Um, there's some real life experiences out there that say harm reduction, overdose prevention is effective. It's the stigma of policy that makes it ineffective in the minds of people.
Yeah, thanks for sharing that. Just remind me, what's the status of the syringe exchange program in Idaho? Has that gone away?
So, yep, we had it in 2019, I think is when it became legal. And July 2024 was the day that it repealed, the repeal went into effect.
Amber, thanks so much. I'm sorry, we have
Sorry.
got to transition over, but Dave, I really appreciate those questions. Amber, I think your responses are so on point. I do just want to read a couple things in terms of harm reduction. Amy said, dead people don't recover. And Karen Kershaw said, I heard an EMS provider once respond with something along the lines of seatbelts don't encourage people to drive dangerously, right? So harm reduction is a good thing. Amber, thanks again for such a great presentation. We are going to transition over at this time to the SEOW team, who's going to talk about alcohol use patterns and health impacts in Idaho. You guys have 16 minutes left, so just enough time. I'll pull up your slides, and Grace and Karen, you guys can get to it whenever you're ready.
Hey, everybody. I'm Grace. I'm going to have Karen come off mute and say hello as well, um, really quick. But we are representing the SEOW, as Shannon pointed out earlier. So, Karen, do you want to say hi? I'm from the Department of Health and Welfare, but I'm not representing the Department of Health and Welfare right now. I want to say that at the top. And so, yeah, Karen, I'll let you come off and say hi.
Hi everyone, my name is Karen Kershaw. I'm a public health analyst with the CDC Foundation. My position is kind of an assignee to the Idaho Department of Health and Welfare, federal assignee. So I'm also not speaking on the behalf of CDC Foundation, the CDC, or the Idaho Department of Health and Welfare.
We're obviously feel the need to get that out there at the very top. Yeah, so I'm the research analyst for the SUD team at the Department of Health and Welfare. But yeah, Karen and I in year 2024 and 2025 worked as coordinator and Karen as chair of the SEOW, and we did a lot of work together. I am no longer the coordinator. Karen continues to function as the chair to date. But I'm just here to talk about some of the work that we did when I was still working with this group, and thought it might all be interesting to you all. So there's a brief that goes along with this presentation, and we encourage everybody to go read that brief out when they have time. You can hop to the next slide. So first things first, saying thank you to this group and just kind of explaining this group. It's a bunch of data managers from a variety of state agencies, and they're listed out right there. I will not go through them, but this work is not possible without the collaboration of everyone that comes diligently monthly to these groups. And then when these reports get done, they contribute extra time, and such a wonderful group of people really interested in understanding the health of Idahoans. And they are just really, really committed to their job. And so it's a really beautiful group of people able to take disparate data sources and sort of make a story out of that data, for the public, hopefully. Next slide. So this is what we'll go through today. Probably an abbreviated version. We're really high level. We only have a couple minutes to chat. Again, I encourage you to go read the brief on your own time. But so we'll stay pretty high level today. That's what we'll take you through. Next slide. Okay, so I'll just kick things off by talking about this. This brief came out in, I believe it was July of last year. So yeah, it's been a little while. So in January of last year, the Surgeon General came out with a report. And this is actually kind of what spurred this report. And I believe actually Karen had brought it to my attention. And in that report, they talk about cancer is the third leading preventable cause alcohol as the third leading preventable cause of cancer in the United States. And I didn't know that. I didn't really understand the connection between alcohol and cancer. And like I'm in this world and have been in it for a little while. And I just was, I don't know, I was kind of floored by that. And these are just a couple other points. So the various cancers that have been linked to alcohol consumption: mouth, throat, larynx, esophageal, bowel, liver, breast cancers, and then other diseases such as high blood pressure, heart and liver disease, and of course AUD. The WHO also came out with a report, I believe in 2024, that said that there's no safe level of consumption, which was also a pretty big deal at the time. They basically said, the more anything that you drink has some harm, and the more you drink, the more harm, basically. And then I just also want to highlight that the CDC estimates that about 178,000 deaths occur due to alcohol in the United States annually. And I just like to bring up the stat that our overdose deaths peaked in, I believe it was 2022 at around 111,000 overdoses. And we talk about overdose deaths a lot, but that's all other drugs combined. So I think sometimes we just see alcohol. Alcohol is a part of it's a social norm, but it's really dangerous, and we don't really talk about it like that. So it's, illicit substances are deadly, but alcohol is as well. And the only substance that beats it, of course, is the other legal substance, tobacco. So next slide. And I'll pass it to Karen.
Okay, so our SOW data briefs, we usually like to start out with an overview of the policies that shape access to that substance in our state. So for alcohol, we looked at our state liquor laws and also retail outlet distribution data that the Idaho Department of Health and Welfare manages. I don't think I have time to get into this slide, so we can go on to the next slide. Just know that this is all in the briefs if you want to read up on that portion. That's all laid out in the alcohol brief. But the first kind of piece of alcohol epidemiology that we wanted to look at was use trends and patterns among populations who use alcohol in Idaho. And so for that, we turned to the BERFIS, which is the Idaho Behavioral risk factor surveillance system. They're a longstanding member of the SCOW. I think a couple of them are on the call this afternoon, and they're wonderful to work with. And huge shout out to them for going back and forth in this data and getting it to where we needed it for the brief. If you're not familiar with the BRFIS, yeah, it's an amazing looking plot, thanks to Jonas. So the BRFIS it's a state-based survey of adults, non-institutionalized adults, and they answer questions regarding chronic health conditions, health risk behaviors, and the use of preventive health services. So it's self-reported data. And all 50 states conduct BRFIS surveys in coordination with the CDC. So for this brief, we asked the BRFIS team to provide data on past month alcohol consumption, binge drinking, and heavy drinking. The definition of heavy drinking is going to be on the next slide, but you can see the definition of binge drinking at the bottom there. Let's see, for the sake of time, I guess I'll just say that we didn't find any statistically significant trends in prevalence between 2014 and 2023 when it comes to past 30-day alcohol consumption and binge drinking. But if we go to the next slide, we can see that we did find a statistically significant trend when it comes to heavy drinking among females. So we saw that there was a significant increase in the reported prevalence of heavy drinking among females from 4.5% in 2014 to 6.4% in 2023. So keep that finding in mind, that trend in mind, and I'll pass it back over to Grace to go over some findings from our alcohol mortality data.
Yeah, and I'll just point out here, there's no line for males because there was no significant trend. So we just focused on females here. It made the graph look very messy when we had both of them. So we decided to opt for findings for only the females. And you can hop to the next slide. Okay, so let's talk a little bit about mortality. So in the year of, I believe it was 20, well, this is a 10-year time frame. So from 2014 to 2023, we saw alcohol-induced deaths increase by 33%. And I want to talk a little bit about what alcohol-induced death means. It includes a lot. Again, go read the brief. But it mostly is reflecting chronic liver disease and cirrhosis. And so we saw from in that 10-year time frame, women death among women increased by 70%, while during that time frame death alcohol-induced mortality among men only increased about 19%. And I think it's important also to call out the age groupings here. So between the ages of 55 and 64, that was actually where most of them occurred, which makes sense because on average, women who die from alcohol-induced death die at the age of about 54, and men die at the age of about 58. I'm actually going to skip over the alcohol-related mortality piece. Just know that alcohol-induced death and alcohol-related mortality are two different things. Alcohol-induced mortality is a little bit more strict, like it doesn't include motor vehicle crashes and things like that caused by alcohol consumption. While the alcohol-related mortality looks at like more, so someone could show up with heart disease and have a history of drinking, and so they may die, and it may be on their death certificate that they passed away from heart disease with an attributable factor being alcohol consumption. And so Artie looks at something a little bit more holistic and estimates that it almost estimates about 2.5 times the average number of alcohol-induced deaths recorded in the state system. So yeah, we'll keep moving here. So some of these trends in context, I feel like we don't have too much time. I hope we've kind of made you excited about reading the report. I guess that's what we can hope for. So what I'll say is we weren't able to dig down into some of this data because we were having issues with some of our like Burfus. Jonas is on the call. He did some wonderful work for us, but we were having some issues at the time with the federal like data systems, like data management systems. So we weren't able to drill down. But what I'll say is like we did find some research nationally that here the top point in 2019, an estimated 96,000 cancer cases were related to alcohol consumption, 42,000 among men and 54,000 among women in the US. And then if you go to the bottom point there, we talk about ages. And so the increases we're seeing are among the age group of 26 to 34 and 45 to 64. And so that just kind of tells you kind of where this trend is happening. And then just showing you that there's a lot of cancer happening, and especially among women. So next slide. So you know what? Unfortunately, I am going to skip this one. I feel bad about that, but she's going to send out the slides and you guys can take a look. We'll skip this one as well. And I'm going to pass it off to Karen.
Okay, so just to kind of bring it back home to some current events, you might have seen this from earlier this year. Previously, in that Surgeon General report that we mentioned at the top, the Surgeon General recommended that, or I guess stated that just 2 drinks a day among women would lead to 5 more women for every 100 women developing cancer, and 3 more men per 100 men of developing cancer. And they advised that we should probably have in the United States some language in our alcohol warning label about the connection to cancer, like we do for tobacco products, but we don't currently. So we wanted to tie it back to that. That Surgeon General report is really interesting if you want to learn more about this topic and the connection to cancer. Like Grace said, I was also pretty floored, and I feel like I have some personal takeaways from this as well, professional and personal. So I really encourage you to check out that advisory from the Surgeon General. And then just, yeah, so earlier this year, you probably saw that HHS and the current administration revamped the dietary guidelines for Americans. And within those guidelines, they removed the previous recommendation about limiting alcohol intake to 2 drinks a day for men and 1 drink a day for women. And the guidelines are now just to consume less alcohol. And remember, 2 drinks is like a scientific drink. It's probably not the drinks that most people are consuming. Like a glass of wine might be more than just 1 drink. So also another important note. But yeah, we are out of time, so we can go to the next slide and move on to the next slide as well. Just with a big thank you for your time and attention. And you can reach the SOW at this email. You can also reach out to Grace and I individually. Please read the brief. Let us know if you have any questions. We also love to hear if there are any topics in your world that you would like to see a brief on. If there's something you'd like to see Idaho data on, let us know, because we are here to help our professionals and the public in our state and just use this data to its full potential. So big thank you to everyone and to the SOW members who are here today.
Thank you guys so much for presenting this data. I feel like we could do an entire session about this. We do have these slides posted on our website, and then I will also make sure to go back in and post that report on there too, so that you guys can access that. I know Grace put it in the chat as well, but we'll make sure that that's ready to go for you guys. We are at time today, so this was a jam-packed session. Thanks you for everyone for joining us. We're going to be back on Thursday, April 9th from noon to 1 p.m. Mountain Time. We have Dr. Norm Litchfield, who is the medical director of addiction medicine at St. Luke's Health System, and he's going to be talking about substance use and ADHD. So we hope to see you then. That is April 9th. Have a great rest of your day, everybody.